Good afternoon, ladies and gentlemen. Welcome in person to the Health and Wellbeing Board this afternoon. My name's Roy Webb. I'm Cabinet Member for Adults, Health and Housing. Just welcome you all, even those that are coming in late. Right, apologies for absence, and I have a long list of apologies. Councillor Lonsdale, Councillor Poulter, Councillor Martin, Stephen Bateman, and Tony Campbell is representing him. David Cox from the police, Paul Brookhouse, who represents the Poverty Commission, is apologising, he's on leave. Ian Fulliger from Strategic Housing, Dr. Magnus Harrison from Royal Derby Hospital, Rachel North, who is on leave, Paul Simpson, the Chief Executive of Derby City Council, Andy Smith, who's on leave, and Meryl Watkins, our CCG representative and Vice Chair, who's also on leave. And then, just to move things on further, I have two welcomes, and welcome to Amjad from Derby Health Inequalities Partnership, and welcome to Claire Mabani from Derby Homes, looking at housing and homelessness on our behalf, and I must say doing a great job. The items introduced by the Chair, can I just ask members that item 7 can be moved to the top of the agenda so that Dr. Clayton can go to another meeting he is due at before this meeting finishes. The next item is that I'm sure all members will know it's Mental Health Awareness Week, and there's lots of activities taking place across the city, and if any of you have any difficulties, then there is information available on the council's website if you want to either find out about what's happened or indeed want to put your organisations in contact with any of our mental health teams. And finally, an announcement from the Children and Young People's Directorate. Apparently, according to Ofsted, they are outstanding, which is really good news for the city, and I think we all would agree on passing our thanks to the team that have worked really hard to achieve this result. So thank you. Are there any declarations of interest? I'll take the silence as none. And then item 4 is the minutes of the last meeting held on the 17th of March. Do I have approval for acceptance of those minutes? Thank you, Yvonne, and thank you, Pervez. So proposed and seconded. All those in favour? Thank you. And are there any matters arising? In that case, I will take it that there are none, and we can move on to item 7 on the agenda, which is Joined Up Care Derbyshire Update, and that's Dr. Chris Clayton. So over to you, Chris.
Found the button, Chair. Thank you. I'll just get the microphone right. And thank you again for arranging to put me earlier on the agenda, but I do, not to put the pressure on, I am hoping to hear all of Robin's section, so I'll be certainly here. The update I want to bring today, you've seen the cover sheet in advance, just sets out where we are as we approach July for the formal statutory creation of the integrated care system for Derby and Derbyshire. And I know this board is well cited on the developments, having discussed it here several times during its evolution. There are two main parts of the health and care bill that I want to cover that we now know will become law from the 1st of July. And those are the Integrated Care Board, the ICB, which is the NHS body that will be created through the Act, and then secondly the Integrated Care Partnership, which is the statutory committee that will be created to frame the partnership that creates the integrated care system. So I'm going to talk through both of those things. Colleagues will remember that the NHS is a very broad family and has lots of different organisations and agencies that work underneath the NHS banner. The new statute aims to help bring those together, not in a structural way, but in a coordination way. And one of the key ways that's going to happen is through the creation of the Integrated Care Board, which for us will be called NHS Derby and Derbyshire Integrated Care Board, or NHS Derby and Derbyshire for short. This body will have the statutory duties that are currently in NHS clinical commissioning groups put into the statute of the ICB, as it's going to be termed, and amongst other statutory duties that will come in, that will be one of the sole roles of the ICB will be to do these two things. Firstly, to deliver its own statutory duties, and I'll set out what some of those are in a second, but also to support that integration within the NHS itself, but also the integration between the NHS and other parts of the integrated care system. So in terms of the readiness of the Integrated Care Board, we've just this morning had some transition assurance governance programme work done this morning, and we are well on track for being statutory ready for the 1st of July. The Integrated Care Board currently has a shadow board in place and has its non-executive and its executive members established, and we are currently in the process of confirming through a nomination process the partner members, of which local authorities are statutory partner members, and we're working through with colleagues as we speak really about that process. So all things are set for us to be structurally ready with a board in place for the 1st of July. The end of the CCG at the end of June obviously means that there will be a shift of both the statutory duties, the functions and the people into the ICB, and that is also in progress and is on plan to be ready for the 1st of July. The main functions of the ICB itself, of course, is being an NHS body in its own right, so its statutory accountabilities include the commissioning of health and care services, and as I say, the functions of the CCGs will be subsumed into those of the ICB. That said, we do want to do things differently than in previous iterations of the NHS architecture, and so the emphasis around the way the ICB will operate will be around collaboration and support and facilitation, and bringing the NHS family particularly together to support that integration of care that's much required for the people we serve. The wider partnership that I'm just going to update colleagues on is related to the integrated care system as a whole, and the statutory body that will hold that will be in the form of a committee. I've mentioned it before, the Integrated Care Partnership, the ICP, and I know colleagues around this table have heard me talk about that before. In essence, that is an equal partnership between the NHS, local authorities and other partners, such as the voluntary sector, and its job is to understand how we improve outcomes for the residents that we all serve collectively, but from different angles. And we're working through, at the present time, how we're going to achieve that. The ICP has met now twice in shadow form. It's got a further meeting in June. And at that meeting, we'll be doing a couple of things. We will be reviewing how wide a remit the ICP wishes to have. And I'll explain that in greater detail in a second. But we'll also be setting out how the ICP will deliver one of its statutory duties, which is to create an integrated care strategy for Derby and Derbyshire. The reason I talk about how wide a remit the ICP may wish to have is because, as we all know, and we've talked about it many, many times, the outcomes that people have in terms of their health are not simply based on the medical nursing treatments that we all know and understand and recognise. They are based on a set of wider determinants, such as their housing, the environment, the wealth that they experience, and so on. And therefore, if we are genuinely here to improve overall health outcomes, we must pay attention to those wider determinants and hence the full determinants of health. You might say, naturally, the ICP would want to cover all of those areas, and that might be a natural conclusion you reach. However, we want to understand, in partnership with the Health and Wellbeing Boards, how we work together and avoid duplication. So there's a really important conversation happening as I speak about what role does the Health and Wellbeing Board want to play in the future, because the Health and Wellbeing Boards continue in statute. There are no changes to Health and Wellbeing Boards, and therefore what does the ICP want to focus on? And there are two broad options being discussed at the moment. Firstly, that the ICP continues its flavour of depth and breadth, which has been around the NHS, public health and social care, including adults and children. Or it takes on a wider remit to cover the full determinants of health, and therefore would include things like housing, the environment, regeneration and health and wealth creation, and that broader socio-economic agenda. Of course, whichever option is decided upon, that would have a consequence, I suppose, if I want a better phrase, on the role of the Health and Wellbeing Board, because I think together we want to make sure we're not duplicating conversation and we're acting, with full effect. And so that's why it's really important. There's an in parallel conversation going on right now through the Health and Wellbeing Boards, both city and county, to talk about what's the role that Health and Wellbeing Boards want to play. And I think during June, July, we will bring those two conversations together and make complete sense across the partnership. So probably going to stop there at that point, Chair, and take any questions. But thank you very much.
It's my name. You talked there about the difference in the wider, the depth one. How would we ensure that there wasn't duplication there amongst some of the other boards that are currently running in the city as well, and that we have a real sort of focus on getting the outcomes rather than spreading it around?
Yeah, it's a crucial question, and we talk about the wiring of the broader system, because if you look at it, there are lots of groups currently looking at different things, and it's certainly not the case that we have any gaps in conversation at the moment across the whole determinants of health. The question is, how do we pull all those together? So you're absolutely right. If we think about Derby City, then the Partnership Board is a really important board that's been established to think about broader socioeconomics. So how do we avoid any duplication between that and the Health and Wellbeing Board and then the ICP? And in my head, and it's only an opinion, there's something about groups that oversee, check, challenge, and I think the ICP and the Health and Wellbeing Boards fit in that space. They take an overview, and then you've got groups that get on and deliver. And I think things like the Partnership Board, the Derby Partnership Board, is about delivery and really looking at the opportunity there. So I think it's about having different roles. There's often interface, isn't there? There's often a bit of blurring around the boundaries. That always happens. But I do think they are distinct. I think from my perspective, the role of the Health and Wellbeing Board to stand back and look at overall outcomes, I think it's going to be crucial. But that's just my single view. Thank you.
Anybody else? Yes.
Thank you, Councillor Webb. Sorry I arrived late, so I didn't quite hear all of that or the exact purpose of what you were saying. I'd just like to echo what Councillor Williams was saying. I think there is a real danger of having more talk and less action if we're not careful. Because we also have, of course, the scrutiny board, the adults and health, and the children and young people. We have an element of bite as far as scrutiny goes, and we do cover a huge remit as well. So I know each body has its own function, but I think my view would be that you need to think about the likely concrete outcomes of each board and then review their purpose and their remit and their raison d'etre really on the basis of that. Thanks.
If I may, Chair, and thanks, Councillor Martin. I think I completely agree with you. There's something about once we've formed a definitive view and we're ready to operate between the Health and Wellbeing Boards and the Integrated Care Partnership by September, that absolute clarity of which group does which is going to be crucial. One of the functions we haven't talked about, and I certainly haven't talked about, is the overview and scrutiny function, which isn't changing as part of this. It remains. And so I think there's a further pulling together that we need to do, across the partnership to understand that role absolutely, because sometimes there can be crossover. Sometimes we've seen scrutiny and challenge in other committees and boards, and I think I agree with you. We do need to have that absolute clarity when we get further down the line by autumn, I would say. Thank you.
Thank you. Any other questions or comments? In that case, Chris, no, you're not off the hook yet. So my understanding is that the NHS will still have to report major changes through to overview and scrutiny, and that the role of the Health and Wellbeing Board will be more looking at the wider determinants of health, and particularly housing and the environment in which we live. And the movement of looking at wider determinants by health and well-being leads to the prevention agenda. And so would the Health and Wellbeing Board, in your opinion, start moving towards further prevention activities to stop more people moving into mainstream health facilities later on in life, i.e. healthier lifestyles and healthier living conditions?
Thanks, Chair. I did think I was off the hook there for a moment, but not for long. I mean, I personally support your view. I'd slightly tweak it somewhat in that I think the Health and Wellbeing Board's future role could be to take that broader view of health and wellbeing than we've possibly done before, where we've had a focus particularly on some of the health service changes, for example, and I think there's a real opportunity for Health and Wellbeing Board to stand back and look at the full determinants of health. The benefit of having the integrated care partnership, if it remained focused on the NHS and care services and public health, would be that would lend an opportunity to the Health and Wellbeing Board to then focus more on the wider determinants and take assurance on those the NHS and social care services. I think you're absolutely right within that. The role of overview and scrutiny hasn't changed in my view, and therefore the statutory requirement to go to overview and scrutiny with major service reconfiguration changes has not changed. And we would certainly still want to talk in the Health and Care Partnership about those sorts of changes as well, but from a different perspective from overview and scrutiny. I think the prevention thing is a really interesting question, because my philosophy is that prevention needs to be across the board. So if you think about the Health and Wellbeing Partnership, Health and Wellbeing Board, when looking at wider determinants of health, all the partners around that table would need to have prevention as part of their work. There'll be things that we all do that need to think ahead. So the Integrated Care Partnership would be part of that conversation, and there would be prevention in our work. We would be looking, for example, tobacco consumption, the reduction in tobacco consumption would be a preventative measure that would still be there. But then, as you say, we'd be wanting to think about housing and the prevention work that can be done there. And we've talked before about housing conditions, damp environments, and so on, as a contributor. So I don't know if Robin would agree or not, we'll see in a report, but there's something about us all having a prevention aspect to our work. So I hope that helps. Thank you.
Thank you. Okay, Councillor Lind.
Thank you, Chair. In relation to, just to expand on that, in relation to the ICS funding, I just wondered how much funding that the ICS will have for the current, for the forthcoming year, how that compares both regionally and nationally, and what percentage of that will be used to support preventative measures?
Thank you. So the budgets for the financial year that we're in now have been set, and we are in train with working through them. I think it's fair to say on the NHS side that the budgets remain challenging. That's not a change in position. We've got a significant amount of demand for services, and of course we have a finite resource. That that budget that the NHS will bring into the broader partnership, in general terms, hasn't overly changed to that we've seen before. There's a real question about the ICS and the equal partnership between ourselves, local authorities and others in terms of the joint budget that we bring to that conversation and the budget that we want to collectively put behind certain initiatives, and that's a conversation we want to have in earnest as a partnership. I'll just remind colleagues that the Better Care Fund mechanism has not changed and will be the principal vehicle for joint partnership working between the NHS and the local authorities, particularly on things, as you say, Chair, relating to prevention and other matters. And I'm afraid, Councillor Lynn, it was the last element of your question. Could I ask you to just go through that one again for me?
Yes. So I would like to know, please, how much funding has been allocated for the forthcoming municipal year, and how much of that is going to be allocated for preventative measures?
Yes, so thank you. We've got. I just want to highlight to the board. It's an important question. So the NHS is setting out a vision with regards to health inequalities, and colleagues, I think, around this table will have heard the term, the core 20+5 movement that's happening across the NHS at the moment, particularly thinking about health inequalities and probably what we have in mind when we think about some of the prevention strategies that we want to undertake. There's a core budget that's been set for that we've put out through the NHS, which we're currently finalising, and happy to bring further details of that through as required. But there's also a full programme that goes against that, and a plan that we want to obviously sign off as an integrated care partnership later in the year. And from memory, I'm wanting to say around September time we'll sign that off. So that'll be in full sight of this board and the integrated care partnership going forward. So happy to bring those details in due course if that would work, Chair. Thank you.
Okay, thank you. Further question, Councillor Lind?
Yeah, thank you. In relation to children's local transformation plan in the ICS, I wondered if you will be bringing that to the Health and Wellbeing Board and also to the Corporate Parenting Board or Children Young Peoples to ensure that looked after children are central to that as well.
I certainly expect so, and I probably refer back to the questions, the theme of the conversation about the partnerships and the boards that are currently in place, and making sure we don't create new structures where we don't need to create new structures. And so my instinct is that we'll be wanting to use quite a few of the current structures to have that joint conversation about those really important joint priorities. So the quick answer to that is yes.
Okay, thanks very much. Is that it? Thank you all. Thank you, Chris, for that comprehensive update. I know it's a case of sit and wait. June is a big month and September is even bigger. So we'll look forward to regular updates on this in the coming months. So now we move back to item 5, and it's our Director of Public Health, Robin Dewis, the COVID Outbreak Engagement Board and Health Protection Board update. Over to you, Robin.
Thank you. So just a very quick verbal update today, because neither of the groups have met since we last met. We've got an Outbreak Engagement Board meeting that's planned, and the purpose of that meeting really is to review our current data sources around COVID, and also to consider what our current plans are and to update on what the plans for the future planning around outbreaks. So we're doing some work at the moment to look at our outbreak planning and how we amend that and adapt that to respond to be flexible to outbreaks of other conditions as well in the future, so that we can be more all-embracing with that. Just from a figures perspective, as you remember last time, we're working now off the Office of National Statistics survey data for our understanding of what's happening within the city. Unfortunately, that survey data this time wasn't broken down because of the bank holiday. So we do have an overarching England figure, but not a Derby figure this time. So our overarching England figure is demonstrating 1 in 35 people infected with COVID, and that's from about 10 days ago. So gives an indication that we're coming down from that high level of around 1 in 13 that we had at the beginning of the year, but there's still a significant amount of COVID there. Just under 3% of the population that are positive at any one time at the moment. So COVID is still very much there, and we're still encouraging people to go forward for vaccination if they've not had all of their vaccines, and not to forget those simple public health measures, and particularly the key one is that you've got any symptoms of COVID to please stay at home with those symptoms and to keep them to yourself, and particularly thinking the most important thing at the moment is about protecting the most vulnerable. So that may be elderly people who are unvaccinated, but it may also be people who've got health conditions in which vaccination has not completely protected them, and they still need us to be cautious around them. So that's really the key message from a COVID perspective. From the General Health Protection Board, we will be having another meeting shortly, and then we'll be able to report fully to the board around those developments next time.
Thank you, Robin. Just a quick update. Have we got those that receive home care, i.e. the housebound, all fully vaccinated, or is that still an ongoing programme?
I believe that should have been completed. I'm not sure whether Chris can... Yeah, it is. Yeah.
Okay, thank you. Any other questions? Yvonne? Councillor Williams?
Thanks, Chair. I was just interested there when you talked about the General Health Protection Board and bringing stuff back to the board here. Would we be able to get an update on the situation with Hep B? So I understand there's been quite a large number of cases, not necessarily here in Derby or Derbyshire, but be interested to know if we have had that here and what we can do about it and how we spread that information and support again.
Just yes, so I don't have the numbers in my mind at the moment, but just on that, so there's been an outbreak of hepatitis particularly within children, particularly in under fives, and there have been a few children who've been really seriously unwell and required liver transplant from that. So it is very concerning. The numbers do remain small, and the UK Health Security Agency have been looking really closely at all of the cases and tracing back to look at any connections. One of the things that they did find a few weeks ago was that more of the cases had been infected within a virus called adenovirus, which is a very common virus, than other people in the general public, and they were looking at whether there was a connection with adenovirus. I think the general message is very much, whatever the cause of this, and there was a suspicion it could be related to viral infection, the simple messages that we've been following all along are still really, really important. So, and particularly for preschool children, it's very much about hand washing, but also watching your child wash their hands and making sure that they're doing it properly, because they do, certainly my children like to waft their hands under the tap and not go near the soap. So really important to get them washing their hands properly. And there has been an association with a little bit of sickness and diarrhea and tummy pain as well. So just remembering again, if children are not well, to keep them at home, whether it be with symptoms of COVID, whether it be with symptoms of sickness and diarrhea, to keep them at home. And if it's sickness and diarrhea, to have 48 hours after their last episode of whatever it is before they go anywhere. Everything we can do to reduce the spread of any of the viruses is going to help. But as I said, the numbers, I can certainly bring an update next time around the numbers, but the numbers have been very small. So even children who do get infections, the risk of developing that is still very, very low.
Thanks. I was just wondering then if there is anything for us, the board, to look at, because of the last sort of 2 years been spent a lot of focus, particularly with our schools and our nurseries around COVID and that message. If there's a further message that reiterates, you know, everyday regular hygiene issues and things like you just said about staying at home, just to go back to the basics again, and refocus, not necessarily taking it away from COVID, but just re-emphasising that there is still other things happening in the world. And whether that's something that we can look at again and assist to do, particularly as we've got the access to the nurseries and the schools.
Absolutely. I mean, we will have a little mention about childhood vaccination in this as well. So there's probably a combination of things to think about, and just that awareness that actually at the minute scarlet fever and chickenpox are also causing a lot of issues from a school perspective as well. So all of the protective measures are all very much the same for all of those conditions, but yeah, we can absolutely have a look at that in the round with the vaccination as well, if that would be helpful. Thank you.
Okay. Councillor Lind.
I know we've spoken earlier in the week briefly, Robin, and thank you for that, regarding residents informing me that they're having difficulty booking vaccinations for 5 to 11-year-olds. Some residents are saying the only appointments they could get are around 3 p.m. when they need to be picking children up from school. I just wondered if you've have managed to, if there is any updates regarding booking, sharing information in the city and booking vaccinations for 5 to 11-year-olds.
Yeah, thank you. So there was a specific question, wasn't there, around accessibility, particularly for children with special needs, and particularly about the environment that they're going into. I haven't heard back, and I will follow that up. But if you have any specific concerns that residents have raised with you, I'm also very happy to take those forward as well around the booking. The personal experience I had of booking all work quite smoothly, but everybody's experiences are obviously quite different. So if there's any issues, very happy to do that.
Thank you. I think it was mainly around probably the sharing of information about when it's available, how to book it, that we need to increase that awareness of how to book and where it's available, when it's available. Yes, absolutely. And in relation to the accessibility, there was that concern regarding the accessibility for children with additional needs in particular, and if those needs were being addressed to enable them to have their vaccinations too. So I would appreciate if you have any feedback regarding that you let us know as well.
Absolutely, yes.
Thank you.
Yeah, I'll let you know. Thank you.
Councillor Martin.
Thank you. Yeah, just a query about the COVID booster programme, really. I appreciate there are other issues developing, and there are many issues, as we know. And there are other health issues in the news, as Councillor Yvonne Williams said. But just on the COVID boosters, I did actually have a quick look myself the other day about, in relation to just looking online, how you find where to find a COVID booster. And I fully admit this could be my own limitations, but it wasn't clear to me where you would go now if you hadn't been boosted, you decided you did want a booster. Obviously you can contact your own surgery, but I know before Midland House you could just walk in. And I went past there the other day and I saw the signs up saying it was still a vaccination. So is it still the case that you can just turn up there for a booster at any time? That'd be one thing. And then the other thing is it, do you feel there's a need for a bit further information at the moment? Because I think people's minds, rightly or wrongly, are turning away from COVID, but yet they still need boosters. And is it really clear to people generally what they need to do if they need or want a booster.
Thank you. And there was some recent evidence published, wasn't there? I'm not sure if you saw it around the fourth booster and how good at improving the effectiveness of the vaccination it has been. So really, really important for those people, particularly the elderly and the more vulnerable from a medical perspective, to go forward and have that booster. So the information around accessing it is exactly where it was before, online and on the 119, but obviously that's not being seen by people. They're not aware of that. So there's obviously a lot more that we need to do to share that information. The vaccinations are at Midland House. I just asked Chris whether they are still working on a walk-in capacity for adults at Midland House. I'm not sure whether that's still available.
To my knowledge, but
Yeah.
as Councillor says, there's been a change in demand from the different phases of the vaccination programme, and so without the specifics at this moment in mind, there will have been a change there naturally in response to demand that's changed. But you're absolutely right, it's still the case that we want everybody who's eligible to have their boosters, and that information is still available, it's still there online in terms of the access points and how. So again, any information that comes through around challenges to that, please send it through, and we'll certainly pick that up. But as I know it to be, it's still available in the way it was before. But we can certainly check, and through, through your networks, help that message to get out there. Thank you.
Thank you. There is a difference for the children because of the special staff that they require on site if it's a children's vaccination. So I don't believe the walk-ins are available for the children. That needs to be booked in advance. But I'll double check around the walk-in. But for those people who believe they're eligible, if you've got access to the internet and go onto the website to book a coronavirus vaccine, it runs through eligibility. You put in your details and it checks if you are and says what the available appointments are for you. The alternative is to call 119 if you don't have that internet access, and they'll run through those questions.
So, if I may, Chair, just for clarity, when you say the website, that's the thing. Which website?
Yeah.
That's one point. And the other point would be when you say, so it's still potentially walk-in for adults, but I'm really thinking about people who've had no booster yet, so who haven't had one, the third vaccine or the first booster, however you want to define it. Is that still available? I know they're moving on to another phase.
So all vaccines are still available. So even if you haven't had your first vaccine, it's still available to have that. The website is book a coronavirus vaccine, but I can get the details of that so that we can share that directly as well, because clearly the information isn't out there.
Thank you, Chair. I think I'm not being critical. I'm just saying that I think that because before we were kind of being bombarded by the information, and then you suddenly realise that you're slightly behind the curve. And my experience was I tried to find out. I didn't know. I don't think I booked it by a website last time. I think I just responded to my GP texting. So I think I may have found it eventually, but I don't think I put in book a coronavirus. I probably put Derby Vaccination Centre. So can you see the issue? I'm not, I'm just saying it may be less obvious now than it was previously. Thank you.
Thank you. No, absolutely. And I think there's some work that we need to do to assist with the NHS promotion of it as well locally. Thank you.
Chris.
Yeah, if I may try and help there. So I've just been looking at the latest figures that I have, and for the Derbyshire population. So forgive me if I set out the full Derbyshire position and not separate out the city position. We're over 83% of the eligible population has been boosted, which is an important figure. It's important because what we've learned through the different phases of the vaccination programme is that when you get to those levels of vaccination, you want to go further, but the methods of going further have to be different. So I think Councillor's right to set out that access points will change because it's a different population that you're wanting to increase that boosted vaccination rate. So What we have been doing, and hopefully colleagues will recognise this, is more of the mobile type of facilities going out over the months. Previously, we set out 4 mobile units going out and trying to do a different delivery approach. And I think that's what colleagues would recognise, is once you get to those levels, it's more of a bespoke programme you need to do. So I think it's an important question about what services are still available, but we need to remember there's probably a better use of resource to increase the numbers once you start to get to those levels that I've set out. But hopefully that's a helpful perspective update on the position as it stands with regards to boosters. Thank you.
Thank you, and I agree, Councillor Martin, clarity is everything, especially when you're on the internet. Okay, thank you for that, Robin. Now you've warmed up, I think we're moving on to the Director of Public Health Annual Report.
Yes, thank you. And the report is due to be published very, very shortly. This is a summary of some of the key points, but by no means all of the findings within the report. I did do some culling down of the information for you this afternoon. And the report, as I said, the work is done, but we're just finalising the production of the report for the publication, and that should be very shortly. I'm not sure, Alison, if you've got a date.
No, not yet. We're just waiting for some final feedback. Yeah. But yeah, anticipating it that'll be kind of within the next few weeks.
Lovely. And I think as we run through all of this information and data in the report, I think just to start off with, sometimes when we summarise public health data, we can appear quite negative. And today what we're talking about are some of the issues and problems that have been found through the work that we've done with the report. But I just wanted to say that the last 2 years has had a significant impact on the health of the population in the city, but there's been some really, really positive outcomes from the last 2 years as far as our ability to respond, our working together, our partnerships and relationships that have been developed. And so although we're identifying significant problems, I think we're in one of the better positions we've ever been in order to understand the problems more and how to tackle them. So I just wanted to caveat before I share all of the information and data with you. So next slide, please, Lindsay. And the next one. So I just wanted to start off with, before the pandemic, we were already in a relatively challenging position in the city. So we know that we've got a young, diverse population in the city. We know that, as most cities in the country, we've got a more deprived population than the England average. Just under 260,000 people live here, and around a quarter of them from an ethnic minority group. And Derby is in one of the 20% most deprived areas in the country, and has been for many years. The life expectancy of men and women is lower than the England average. So that's how long an average person born in the city would expect to live. And we know that that differs really considerably across the city, depending on which area of the city you're born in. And the health of the people who live here in Derby is generally worse than the England average. And again, that's a picture that's generally seen within cities in the country. The next page, please. So life expectancy in general across England has been increasing, and has been increasing in Derby. But from 2011, we've seen life expectancy nationally generally stall and slow down in those improvements. And there are concerns that we may be moving towards a dip nationally in life expectancy now. And in Derby, what we see is, for both men and for women, an average of around 10 years life expectancy difference between our most deprived and our least deprived areas. And we're a small city, that's a few miles difference in where people live. And this is the largest difference that we can see across the East Midlands. And part of that is about Derby as our city and how we are made up, and our population and why they come to live here. So within Derby, we have some very affluent populations. We've got some really big industries in the city, some very skilled workers, and we've also got significant areas of deprivation. And many other cities don't have that stretch in the variety of the population that we do. Now, recently, the inequalities in the life expectancy gap at birth for males has reduced, but unfortunately, this is due to a decrease in the life expectancy of men living in some of our more affluent neighbourhoods and not to an improvement in our most deprived populations. So although the difference is reduced, it's not for the reason that we'd want it to be. Just pop to the next slide, please, Lindsay. And these are just some summaries here. So we've got males on the left, females on the right, and the thick black line you can see is, on average across England, what is the difference in life expectancy in years between on the left for men and on the right for women. So you can see that across all of England there is a difference between our most and our least deprived populations. But the blue line across the top is what we see in Derby. So we can see on the left-hand side for males that the difference was up around 12 years and has been declining down to around the 10 years. But for women, we spent some time around 8 years in that difference, and that has now been climbing to 10 years. So we can see that they're now very, very similar in the differences for males and females. Next slide, please. So healthy life expectancy is the other important measure that we use, because that's the number of years that we'd expect you to live in good health. So not just how long do you live for, but how long are you living well for. And although we're living longer, healthy life expectancy is actually decreasing. So people are generally living longer in poorer health. And we know that that poorer health, as Chris mentioned earlier, is related to many different aspects within our life. So in Derby, the healthy life expectancy for males is just over 60 years, and for females is just over 58 years. And that's really, really crucial, particularly as we see retirement age increasing. So we can see that we've got an average in our population of people who will be entering into poor health before they actually reach retirement age, which has significant impacts on their abilities to work, their income, and that in return has a significant impact on their health as well. So for some women in the city, this can mean living almost 25 years in poor health, which is a really, really significant portion of life. And our inequality in healthy life expectancy for males and females is around 19 years. And again, we are in one of the top local authorities in England for the widest inequality in that healthy life expectancy. And again, that relates to partly the distribution of wealth and income across our population. And the one after that, please, Linz. So when we think about COVID in the city particularly, just a reflection that as we've been through the various waves of the pandemic, we've actually seen different groups impacted differently during those waves. And what we can see is that during wave 2, the infections were distributed across age groups from the working age and also those in the 80 and over populations. That's the blue lines in the graph on the right-hand side at the top there. What we saw in the third wave, which was May until August in 21, is that the older population was much more protected and that the larger figures were actually in the younger working age groups. But we can see at the bottom right-hand corner there that over the period of time that we're looking at, that there was a very much a differential distribution of infections across the different populations by age group. And if we just go on to the next slide, Lindsay, this then demonstrates also the difference that we see by males and females. So in the top right-hand corner there, we've got the number of cases seen by females and by males. In the bottom chart there, the difference between wave 2 and wave 3. So in wave 2, much greater impact on women. By wave 3, it was much more balanced between men and women. And the next slide, Lindsay. So we also think about our different communities by ethnicity, and we knew quite early on in the pandemic through the Public Health England disparities report about the differential impact both on the numbers of infections but also the outcomes of those infections by ethnicity from the national population and then also from our local population as well. So we have the ethnic groups across the bottom there, and you can see just the range of impact across those groups, and we know that the other mixed ethnic group, the other ethnic group, and also the black ethnic groups most significantly affected by the numbers of cases. And the next slide, Lindsay, thank you. So when we think about mortality, this chart just summarises mortality by age over 2020. So we did some detailed work to look at the deaths in 2020 from COVID. And you can see from this, it starts with the younger age group, 30 to 39, with the blue bar, and stretches right up to that green bar, which is the over 80s. And you can see that at every time period that we look at, deaths are greatest in the older age groups. But the impact was very much greatest in the first wave from a death perspective, and that has reduced over that time. You can see the impact of the wave then in the autumn of 2020 with that increase in deaths. So for 2020, there were 400 deaths between March and December that were COVID-19 as a confirmed cause. The latest data that I looked at this morning is up to late April, and that gives us a number of 954. So we're aware that deaths continued, and particularly in the wave that came in January, February 2021, there was a significant number of deaths occurred then that contributed towards that. And at the point in 2020, 59% of those confirmed deaths occurred in people over the age of 80. And the next slide, please, Lindsay. And when we look at excess deaths, what this slide summarises is the main reason for the causes of deaths, and this is from death registrations in 2020. And you can see that the blue bar is the pre-pandemic areas, and the orange bars are those that occurred during the pandemic. And I think the detail on the left is less important. The important thing is that bottom line is the COVID-19 deaths, which clearly occurred in 2020, didn't occur before then. And for many of the other causes of death, what we actually saw was a decrease in those causes of death over that time. So when we look at the number of COVID deaths, that doesn't directly correlate with the number of excess deaths, because there are a few causes that people were dying less from, if that makes sense. So in Derby in 2020, there was approximately 390 excess deaths, and our latest data for that, as I said, up till late April, was 599 excess deaths. And we've seen some periods of time, particularly with the peaks of the waves, where we've had significant excess deaths from all causes, and other periods of time where we've had less than expected deaths from all causes. Next slide, please. There's just a couple of slides on vaccination, and again, the detail is less important. This is more about the trends and the variation that we've seen. The first point to say is these charts are both summarising vaccination uptake, the top by deprivation and the bottom by ethnic group. The bar on the left-hand side, the darker bar, is the first dose, and the bar on the right-hand side is the second dose. And really, universally, you can see that first doses are taken up more readily than second doses. So generally speaking, during second and then future doses, we tend to lose people from that vaccination uptake over time. And what we can see here is, from a deprivation perspective, a general trend that our more affluent populations have taken up more of the vaccination than our more deprived populations. And then from an ethnicity perspective, that there is significant variation across the ethnic groups in relation to uptake. And the next slide, Lindsay. And this then summarises the uptake by age groups. And again, you can see certainly from an over 50s perspective, some really, really high levels of uptake there. And as you go down the groups under 50, you see as the groups become younger, then the uptake decreases over that time. And we have a vaccine inequalities subgroup that is continuing to work both on COVID vaccinations but also on other vaccinations as well to look at the uptake across all of these, across age groups and across deprivation and ethnicity, to look at areas where we have lower uptake and to consider what engagement with communities can be undertaken to assist with that uptake and to increase it. Next slide, please. So the next part is just really to consider, we took significant actions during the COVID pandemic to protect people from infection, and those actions had consequences. And not that we shouldn't have taken those actions, it was really, really important that we protected the population from an infection, and we know we've seen some of that modelling which demonstrated how many deaths we could have expected if we had taken no action. But it's important that we consider the impact of those actions and think what we can do to improve the health and the life chances for the city now that we are moving towards a different phase of the pandemic. So the next slide, please. So one of the key areas is obviously around child development, and I'm sure you'll have seen a great deal within the media reports as well around concerns. So we've got some national and some local summaries of information here, but 40% of schools and childcare providers in November, so that was November 2020, so that was after the first wave and when schools and childcare providers were back working. They noted that children's personal, social and emotional development had fallen behind. And they also noted that children entering into reception classes weren't meeting their school readiness targets in a way that they were prior to the pandemic. And although locally there's been a huge amount of work on school readiness and some real year-on-year improvement prior to the pandemic, and we had just around 70% of the population of reception children who were ready for school in 2018, 2019, the concerns are that this impact of the pandemic and the change in the socialisation and environment that children were learning within will have made a significant difference to that. And we have some softer intelligence from speech and language interventions and also some anecdotal information from schools that are concerned that communication and language has deteriorated over this time as well. So some really key areas for both schools and our public health nurses to tackle. Next slide, please, Lindsay. From a vaccination perspective, there has been a significant impact on the routine childhood vaccination uptake, and this is really concerning to us, particularly with the increased mixing and, as mentioned earlier, the increase of infectious diseases that are being spread amongst children now that they're back to their normal activities. And there's a few contributions towards this. First is possibly that message that was sent out early on about protecting the NHS and people being reluctant to put routine demands on NHS services because they wanted to ensure they were available for urgent care. There's some emerging evidence that some parents from certain backgrounds will have felt more vulnerable and will have been too nervous to come forward to those healthcare settings. And also there was a lack of that support and less formal information sharing that parents will have received through attending support groups or other play centres that they would have been doing during 2020 to receive that information. As I mentioned, the Vaccine Inequalities group is continuing to look at this along with the COVID and the flu vaccination as well. So next slide, please, Lindsay. So from education, and this is our local information, we as nationally, the schools closed by the 20th of March to face-to-face learning for the majority of children. There were some children still going into school if they were vulnerable or key worker children, and most of the education was being delivered at home. And then since that point, there's been various either universal moves to at-home education or particular issues with certain schools when they've been in outbreaks or they've had to isolate certain class groups or years. So episodic home learning during that time for many children in the city. And there's been some work with focus groups with children and young people having conversations about this and the impact on them, and their concerns around the loss of structure in the school day, struggling with the motivation to work during that time, not having the resources that they would usually have at school, and particularly for those in Year 12 in 2020 struggling to adjust to the transition and the change in environment. And children struggling to feel the support that they would have felt with their peers and with their teachers in the classroom during this time. The next slide, thanks, Lindsay. And we know, as with all things, that children from most disadvantaged backgrounds will have had a worse experience of this. So the most deprived schools nationally have reported that 1/3 of their students didn't have adequate access to the internet or electronic devices. And this was just 2% for the most affluent schools, so a really stark difference. And across the country, and specifically in Derby, there was a great deal of work around ensuring that children could access IT services, that there were laptops and other equipment that was shared with those children. But despite the best efforts of all of the schools, there will have been people who dropped through the net on this. And teachers in the most deprived schools nationally have also reported around the quality of the work. So that quality of that work that was submitted remotely was of lower quality. And locally, as an opportunity area, we've had some really good success in closing the attainment gap pre-pandemic, but clearly these issues are a concern and something that will continue with that work around the opportunity area and the legacy from that as we move forward. Thanks, Linz. So from an obesity perspective, particularly thinking around children, being at home, not having that activity at school, they were permitted to do 60 minutes of exercise outdoors during that time of that first lockdown, but around 1/3 of children, just under 1/3 of children, didn't leave the house each day during that time. And an increase has been observed in the proportion of overweight and very overweight children between 2019 and 2020 and 2020 and 2021. This has happened, we're no different to the national picture, but we can see that locally as well. And as ever with our childhood obesity figures, the rates in our most deprived areas are worse than in our most affluent areas, and in fact our rates of obesity in the deprived areas are over twice that in the most affluent areas. So we can see that real disparity across the city. So at reception, that's our 4 to 5 year olds, the proportion of overweight children has risen from just over 8% to over 13%. And the very overweight children has risen from 6 to 10%. So just thinking that 1 in 10 children starting reception are currently very overweight. And we know that as they age during that time in primary school, that the proportion of children who are overweight and very overweight increases. So we know that does worsen during that period. And there's huge impacts from the last 2 years, but we're continuing with our work. We have a childhood obesity strategy that sits under the integrated care system, and the work under that continues and has been reinvigorated really over the past few months. Next slide, please. From a children's mental health perspective, again, the focus groups in conversation with young people locally demonstrated high stress levels, pressures from completing schoolwork at home, being socially isolated, and worrying about the virus. And importantly, children have worried about the virus themselves, but very much also about members of their family who could be significantly impacted by catching the virus. And I think that's a significant impact for them, feeling that they could potentially transmit the virus as well to vulnerable family members. There's also increased job losses among young people and parents and carers, and this has added to that tension and stress for young people and concerns about finances. So we've estimated that up to 4,500 children between 0 to 17-year-olds in Derby will experience mental health problems due to the pandemic. And that's a variety, it's a range of mental health problems, and certainly not all would need specialist intervention. but it's around 8 in 100 children in the city that would have some mental health consequences of the pandemic. And again, as with all impacts, it's disproportionately affecting our most deprived population. And along with that, an increased risk over this period of adverse childhood experiences, with children being at home a great deal of the time. If home isn't a safe place, then that will have exacerbated those experiences for them too. Next slide, please, Inns. So from our response to this locally, there's been various actions taken during the pandemic to tackle this. So a combination of digital, online and face-to-face appointments to review children and young people who need to access mental health care. The Emotional Health and Wellbeing website was launched ahead of planned schedule so that it could respond to the pandemic, and it's used as a signposting site to local information for children and young people to seek support. And a free anonymous counselling service was made available for children in Derby, COOTH, which has supported people particularly with anxiety. And the Emotionally Healthy Schools programme work is underway and supported through the opportunity area as well. Next slide. So when we think about employment and income, so thinking about those older young people or family members, we know that in the early phase of the pandemic, 28% of adults experienced a decline in their family finances. And locally, we saw an increase in job seekers allowance and universal credit claimants in 2020. And they continued to climb up to March 21 as well. We know that the 18 to 24-year-old group was significantly impacted, most probably related to the types of work that they were undertaking. And by March 2021, 6.4% of the population were unemployed, which had increased 2% from the previous year. And this is really the backdrop of our current views around what's happening from an economic perspective and finances for families across the city and across the country that we're anticipating now. So within this context is then the pressures around inflation and fuel costs and food costs and all of the other pressures that are coming onto families in the city. And I realise Paul isn't here today, but just wanted to acknowledge and welcome the work of the Poverty Commission and how this contributes, and perhaps it's part of our thinking around how we work with these issues alongside the Poverty Commission too. Thanks, Linz. So just a quick summary through around what's happened with health behaviours during this time. We've all got our own personal reflections, I'm sure, around our own personal habits during the past couple of years. But up until November 2020, 61% of adults in Derby achieved over 150 minutes of physical activity per week. But 32% of adults achieved less than 30 minutes of physical activity per week. So a significant increase was observed in those who were physically inactive compared to the previous year. So the previous year it had been about a quarter who were physically active, but it had moved to nearly a third who were physically inactive. And that, as with all of the other factors we've discussed, was differential across the city and the population. So 70% of people in the highest socio-economic group achieved their 150 minutes, but this fell to 57 and 60% in the middle and lowest socio-economic groups. And some of the largest declines in activity have been in some of our ethnic groups, particularly around the Black, Asian and other ethnic groups within the city. And over this time period, Derby Active at Home was providing remote fitness services, health and wellbeing advisors, running live video classes, lots of innovative work. But there's still some gaps there that we need to look at and to pick up now that much more face-to-face delivery is happening. Thanks, Linz. From a smoking perspective, prior to the pandemic, nationally it was just under 14% of adults were smokers, and in Derby it was just under 17% who were smokers. And there's limited data around what's happened during the pandemic. We know that there has been a good percentage of people, an increasing percentage of people reporting that they'd quit smoking in 2020. There was a particular drive and encouragement to do that at that time. But those people who were smoking, there were some reports around stress smoking more frequently during that period. And when we look locally, what we do know in a city is that in Derby, if you are a routine and manual worker, you're 4.7 times more likely to smoke than if you're not. So really significant inequalities in smoking across the city relating to occupation. Thanks, Liz. And then if you look at alcohol, we know that nationally high-risk drinking has significantly increased in the first part of the pandemic, up to almost 20%. And in Derby, up until June 2021, we had a 18.9% increase in the number of people in alcohol treatment, 62% increase in new presentations for alcohol treatment. And in a survey, 28% of people reporting that they'd increased their alcohol use, even if they weren't coming forward for help or assistance. And we have had for a number of years high rates of alcohol-related hospital admissions and deaths in Derby. And these have been significantly higher than the national and regional averages. But the pandemic does seem to have accelerated these trends. And we can see that 1 in 3 of our hospital admissions or deaths are from our most deprived populations, and 1 in 10 are from our least deprived. So again, we see a real clear differential between our population. Next slide, thanks. And just to mention gambling, and it's not one of the areas that we've particularly talked about or looked at before, but I think it's really important, particularly in the context of employment and income that we looked at earlier, and the issues around finances that we're anticipating building through this year. So there was a decline in regular gamblers during the first national lockdown, but what we have seen is a change in the type of gambling. So we've seen that those people who engage with online gambling has significantly increased. And a trying out of new online gambling, and a particular risks for this gambling around people who were furloughed, living alone, or otherwise unoccupied over this time. And even as the restrictions have eased, we've seen that both some of our ethnic groups, people who are current smokers, or people who had low educational attainment, so certain sections of the city who are more likely to continue gambling at high rates, and the concern that perhaps is within our most vulnerable people who are struggling most with their income. So this is something that we're really keen to look more at, to understand the impact and to see what else can be done. Thanks, Lindsay. And then just a couple of mentions around access to healthcare services. So we know that there were around 210,000 people participating in bowel, breast and cervical screening per week in England before the pandemic. And at the beginning of the pandemic, some of the screening programs managed to continue, some were more focused and some had to be paused. And that did develop a waiting list of those who were due to have screening. There were approximately 3.4 million fewer diagnostic tests performed. That's around a third fewer diagnostic tests in that first period up to August 2020. And there were delays in some of our cancer pathways as well and diagnoses. So in the UK, over the next 5 years, it's anticipated between 3,291 and 3,621 additional deaths to be expected from those cancers due to this period, both from a later detection but also challenges with treatment. So locally in Derby, there was a sharp declines which reflected the national picture in urgent cancer referrals. This is quite possibly related to people not wanting to come forward with those symptoms and perhaps due to challenges around access as well. And UHDB Hospital reported that referrals fell by around 75% in May 2020, so really significant numbers not being seen. And in Derby, prior to the pandemic, so in 2018, only 47.5% of our cancers were diagnosed at stages 1 or 2, and this is a really, really key measure for us, because if cancers are found at stage 1 or 2, the chances of curative treatment, or perhaps treatment that prolongs life to a significant extent, is much increased. And so work ongoing to look at how we can improve both prevention but also the uptake of screening as well. Next slide, please. So from a planned care and surgical procedures perspective, prior to the pandemic, there was around 4 million people awaiting on the surgical procedures lists. And that went up to around 10 million in February of last year. There were around 100,000 patients who'd had joint replacement surgery cancelled during that first national lockdown, which clearly would have had a significant impact on their quality of life and their ability to function. And by September 2020, 140,000 patients in England have been waiting for over a year for surgery, which was 100 times the number in 2019. Approximately 13% of older adults had had cancer-related treatment cancelled in that first year of 2020. And 40% of older adults reported feeling less confident visited their GP surgery. And I think that's key. The two aspects of this, one being the restrictions within healthcare services and the challenges in physically delivering those services, but also the anxieties and concerns of individuals to come forward at a time, has been offering practical support and help across Derby. But obviously there's significant work that we need to do along with the NHS to support in this recovery. And just aware, particularly around this recovery in the waiting lists, the NHS nationally has been doing work to look at the demographics of those individuals on those waiting lists, and particularly considering the ethnicity of individuals on those waiting lists. And I'm aware that there was an article published this morning around Derby Hospital's findings from that, and the significant issues around recovery in a fair way to ensure that people of all ethnicities in the city can access services in the same way and have the same waiting times. That work sits with our integrated care system health inequalities strategy, and is very much ongoing work across all of the ICS. Next slide, thanks. So you'll be glad to know I've got to the end of my slides, but ready for a conversation really. As I said, we had significant challenges in health outcomes before. We know these challenges are significantly worse. We know we're really similar to other cities across the country, but there are real challenges. And what's the response of us as a health and wellbeing board to these issues? And just picking up on that conversation earlier with Chris as well around what our role as a health and wellbeing board is, how we're ensuring that progress is made, how we relate to those local other partnerships who's also working to improve these issues, particularly the Integrated Care Partnership, but also thinking about the Poverty Commission as well, as I mentioned. And our developing strategy, are we focusing on the right outcomes? Are we things that we're missing? Are there other things that we need to consider? So very happy to have a conversation about that.
Thank you, Robin. You pulled no punches, and I've got to say that's very comprehensive, even if it's not the complete report. First question I would ask is, where is this report going? I mean, it needs to go or come here to the Health and Wellbeing Board, the Poverty Commission, a lot of our housing groups. So how far and wide will this go? That's the first question before we get into detail.
So our ambition would be as far as wide as we can manage, Alison, wouldn't it? So once we've got to that point that we've got the final publication, then the next stage with any DPH annual report is very much about sharing that findings. So the Integrated Care Partnership will be a key place as well that I'd be taking that to share that information.
Would this go to things like cancer charities, particularly in relation to some of the cancer services that have not been accessed or not been available during the pandemic? Would it go to schools and children and young people so that they can react to some of the issues? That's the sort of thing that I think we as a board would need to know rather quickly before the full report is published, because we are going to get a lot of questions on this, and I do appreciate the work that you and your team have put into this. If I could first call on Councillor Lind.
Thank you, Chair. Thank you for such a comprehensive report today. However, I'm really concerned because I don't seem to have been sent this report in preparation for this meeting. I don't know about anybody else, so I haven't had any prior sight to it. And I'm sure you can appreciate there's a lot of information to absorb, and I don't think it's conducive at all to informed discussion on the report that you've presented here today. So I don't know why that's happened, Chair. Can we be sent a copy of this presentation?
Absolutely, I'm very happy to share the presentation. The report itself is still in its final amendments and approvals. We were hoping that we were going to actually have the final published report to share today, but that hasn't been possible. But very happy to share all of those slides.
Councillor Martin.
Yeah, I'd also like to say thank you very much for that report. I'm sure everyone here has found that one of the more compelling reports we've had for a while in many of our committees. Compelling, comprehensive, and also concerning. And I'm sure everyone will be concerned about the impact of the pandemic. I think, to be honest, to me, it's not particularly, a lot of it is not a surprise, but it's about seeing that statistically, outlined statistically, more factually, more evidence, nuanced. So, yes, it is very concerning. I've just got a few points to make. I mean, I could make many, but I've just a few, because I'm sure, as you say, we need to discuss this, and we need to, as Councillor Webb says, there's a lot of response that needs to be thought through on this, on a whole number of levels in a whole number of areas. But just the thing on the education disparities and inequalities and deficits. You know, the Labour Party and the Labour Group have been calling for adequate catch-up funding from the government for over a year now, and to have specific mental health support put into schools. And that adequate funding never really arrived, just a very token amount arrived. And I think now is the time to renew our calls to government for more support for children in schools, particularly those who have now been concretely and specifically identified as being particularly affected by this. And we know that is some of the groups that are already very deprived. And before I just go on to talk about that a little bit more, can I just add as an aside as well, within the education framework, is that it's clearly not part of your remit, but I would like to just, for the record, comment on the impact the lockdowns and the pandemic had on many teachers too, who struggled with what they were asked to do or had to do. And in fact, in many schools, it's still a battle every day because of staff absenteeism, or not absenteeism, I apologize, absences because of COVID. and all sorts of problems ongoing. But obviously it was very intense when they were teaching from home. And for the mental health impact of that on some teachers was overwhelming, and not in Derby, but tragically, I knew a young man who took his own life because he couldn't cope. And I think many of us will know incidents like that. So I think the impact of the lockdowns on young people was always going to be really quite damaging. And I think your report shows that in many ways. And so I think we do need to think about, Chair, about what we can do to seriously address some of that impact. And I suppose one point I am specifically highlighting today, given the way you've highlighted it in the report, is what can we do and what efforts are being made to address the disproportionately negative impact on many of our BAME groups in the city, who have suffered more and are not on a pathway to recovery as quickly as the other groups. So are we going to keep on highlighting that ethnic question every time this comes up, and every time is a matter of looking at the allocation of funding? Thank you.
Thank you. There's a few aspects there. Firstly, on the teachers, absolutely agree. It's been really, really challenging few years for them. And just to acknowledge really that other frontline staff as well, so the NHS staff, but also those individuals who've been out to work, often felt what a luxury it is to sit with my computer at home when many people do or have over that period had to go out. And that's I'm sure taken a significant impact on many people, and I think it will only be over the next year or so that we really fully understand that impact, both from a mental health perspective but also from the resilience of services and what we see as far as our staffing is concerned across the public sector. I think there's a chance that we will see that impact as people become tired and worn out really from all of this. So I think there's plenty yet to come, and just to note on that as well, that we still don't fully understand the long COVID impact, and new cases of long COVID are still occurring. So there's ongoing impacts from this that we will need to fully understand. You asked a question specifically around the impact on BAME populations, and I'm working with the integrated care system on their health inequalities strategy, as I mentioned earlier, which is really, really key from a health services perspective and thinking around access and experience and outcomes from services. It's really impacting all the way along. But also, Siobhan is working very closely. I'm going to turn around to Amjad. I don't know, Amjad, whether there's anything you want to say from a Health Inequalities Partnership perspective.
Thank you. In relation to the inequalities question, firstly I want to commend Dr. Robin Jewis and a team in Derby of taking a proactive step right from the outset, engaging with the community to co-design firstly an effective comms strategy. I'm working with Derby City Council, and then secondly it was about seeing from as a consequence of the disparities report, seeing that where we and how do we sort of better the situation and address the inequalities that have been prevalent for such a long time. And first thing that come out of that report was the lack of trust, the historic lack of trust between communities, BAME communities and services agencies, in particular the NHS. So to address that, it was imperative that community buy-in we take that on board to be able to address some of these inequalities, and for that it was the whole co-designing. So we formed the Derby Health Inequalities Partnership, and this partnership was different because it wasn't just led by public health. It was actually it was a joint initiative between communities, our BAME communities, and public health. I'm one of the co-chairs alongside Siobhan Horsley, who unfortunately couldn't be here today. So what we said was, we gathered, there's currently 26 members of community organisations predominantly from the BAME community. We gathered them to say that, look, this is the piece of work that we want to do to address the inequalities, or we're setting up this partnership. How do we go about it? And something that come out right from the outset was public health and other agencies, including NHS, have data and they work on that data, but often they don't come and speak to us, see what the human experience is. So we said, okay, the first thing we were going to do is we go back out to communities, and the people going out to the communities are respected leaders, organizations that can relate to the community, and then they carry out this consultation and in the form of conversation. So that ran from December up to April of this year, and we're currently putting that report together. We did have a meeting this morning around that, and there's a lot that's come out, no surprises, a lot of frustration, a lot of anger, and then this article in the Telegraph this morning that people from Black, Asian, minority, ethnic communities are on waiting lists, have to wait 11% longer. So it's so that does add to the frustration. But going back to it, it says around what's being done. So the Health Inequalities Partnership is looking at sort of the core 20+5 program that I forgot the gentleman's name. Chris mentioned. It's that's going to be, some of that work's going to be falling under the Derby Health Inequalities Partnership, and for us it's about empowering communities. It's getting back out to the communities and letting the community lead on this and letting them take. But it's going to take a long time. This trust, this lack of trust that's been within communities, it's a build-up. It's not going to go away overnight. And that's where we're at with the Health Inequalities Partnership. We have the scope of the health inequalities, three things. Number one was the community consultation. Number two was health promotion and awareness within communities, led by communities. And the third one, which I feel is probably the most important, is the Derby Health Inequalities Partnership be a partnership that holds the NHS and other service providers in the area to account. And we've got to hold them to account, because in the past a lot of money has been pumped into areas to address these inequalities or address issues, and nothing really happened, and there's no impact. There's no real measure of impact as well. So, and often we refer to this, they become box ticking exercises. So we've got to really scrutinise any work that comes in, and I feel that the role of the Health and Wellbeing Board, it needs to be that. Needs to hold, help the DHIP and any other partnerships to hold service providers to account. And from that, that's how we're going to build trust within communities, and we're going to be able to address some of these concerns. So going back to it, the DHIP, we had our 6th meeting today. We're still in the early stages. We're at the point of writing up that report, which hopefully in the next 6 to 8 weeks should be ready, and then that will be circulated, and then our action plan is going to be based on that, because we want the community to be part of the co-designing, co-producing.
Thank you, Amjad. Very enlightening.
I've got a question as well, to be fair. It was around the child. So that's if it's finished. Yeah, it was around the childhood obesity, and we know that historically there's, within our sort of more deprived communities, in particular our BAME community, this has been a concern, and a rising concern, and now obviously it's clear that COVID has just increased that massively. Is there anything public health's doing, or is there any resources that have gone into, and the strategy being amended, adapted to further enhance the work that's being done to address the whole childhood obesity, which we know then leads to wider health deterioration, including mental health?
Yeah, thank you. And so the strategy was paused in 2020, as you can imagine, and then the work was reinvigorated last year, and it's Siobhan that's leading on that for us. And there was a key priority from last year that was considering around treatment services, because that was the initial identified area of gap, that actually we had children who were significantly obese, that school nurses were struggling to find the support for them in the system. And so that was the initial priority to work on. But as you can imagine, there's a breadth of work around there that's much more focused on prevention, and also thinking about health in the broadest term, and moving away from thinking about weight as part of your appearance, but weight being part of your risk for future, as you say, for mental health issues, but also for physical health issues as well. So yes, I'm sure you will be having a conversation at DHIP with Siobhan about the childhood obesity strategy, but yeah, thank you.
Okay. Yvonne.
Thank you. I think there's another benefit or good thing that has come out of COVID. We've just heard a little bit about it there, and that is about the co-production, the co-design that's going on across all areas now. Because I think what we've learned through the pandemic is particularly that lived experience and that knowledge base is actually what we should be listening to help develop and mould our services. So it's good to hear that it's happening across the system, and we know that it is, and it's having a higher impact. So I think we need to acknowledge that and to work with it and to learn more from it, because it really is impactful. So I'll put that bit aside. I've got a couple of other questions. So my first question is on the mortality rates. And is there some, and I'm sure there probably is, some deeper analysis done in terms of the reasons for mortality, both locally and nationally? And are we able to then drill down into those if there are specific spikes in certain reasons for that mortality? And are there any trends there that we can then focus on here as the board? That was my first question. And the second question was on the activity rates. I do recall, I'm not sure whether it was here at Health and Wellbeing or another forum, but in terms of the activity rates, not just amongst our BAME community, but also between male and female. I understood that the female rates actually really declined during COVID, and I wondered whether there was something else that we could look at there in terms of, along with trying to increase the BAME rate, that we could look at the female rate as well. And then my third and final question was about the uptake in vaccinations, not just for COVID, but for amongst childhood vaccinations. I know you mentioned that there was a decrease in that, because prior to COVID, I hadn't really heard a lot, whether it's professionally or socially, about parents saying, you know, I'm not going to take my children for their childhood vaccinations. You know, there was one or two every now and again that you heard, and there was those, you know, spurious links to MMR and things like Crohn's and things like that. But have those childhood vaccinations that are regular and part of our lives really now, have they decreased? Because that would be really significantly worrying for, as you mentioned earlier, the increase in things like chickenpox and measles. So rather than being a couple of days or weeks off school, it could be life-threatening, couldn't it, if you've not had those vaccinations? So that was really concerning for me. Thank you.
Thank you. So I think there were three there: mortality, physical activity, and vaccination. Got them in right. So from a mortality perspective, we did a detailed piece of work around the deaths in 2020, and a very small number of those deaths were COVID alone. So COVID may have been the cause of death, but the majority of them were related to underlying health conditions, respiratory, cardiac, some neurological conditions as well, which And as you'll have seen from it, the deaths also very much relate to both being male being a higher risk and being older a higher risk. So we very much reflected the national picture from that. And the general learning really from that, I think, for me, is that if you have poor health for another reason and you catch an infectious disease, you are at higher risk. I think we do know that from experiences with flu, but I think it really brought it starkly forward for us. And along with that, also, obesity was a part of that as well. So we know that that also increased the risk of serious outcomes. So I think we've got a group of areas that we know made more severe outcomes that we can start to tackle, that are already part of the things that we were tackling, I would say, but we can identify that. And then also what we have seen is the fantastic impact of vaccination on those death rates and the real difference that vaccination has made, although not eliminating those deaths, really, really reducing that risk, which is hugely positive. But unfortunately, as mentioned, we are still seeing some deaths, and we are still seeing some people developing long COVID as well. So those consequences are still there for us. From a physical activity perspective, women have always been poorer. I confess I'm one of those that's not brilliant at physical activity, and it is a challenge, isn't it? Very much from school-age children, really. And what we've learned over years is that actually adolescent girls are the point at which physical activity starts to wane. And that's a really key age group for us to intervene and encourage with appropriate physical activity that engages them and isn't necessarily competitive. But obviously we link into the Move More Derby strategy from that perspective as well, and increasing physical activity is part of that whole strategy. And I think we need to reflect on that, our learning from the pandemic around what we can do to support particular communities. From a vaccination perspective, there is a concern that concerns about COVID vaccination may create concerns about other vaccinations. I am concerned about that. And we did well with vaccination, but there was still some areas that we could have improved both locally and nationally. So I think there's a lot more to do. And as I mentioned, we've got a county-wide vaccine inequalities group that Siobhan sits on that looks specifically at which groups are not coming forward for vaccination and alternative ways, different ways of engaging and contacting and understanding concerns. And our aim would be that all parents are informed enough to make that choice. And ultimately it is up to parents to make that choice, but we want to make sure that they have genuine, clear information in order to make that choice as well. We monitor the vaccination and immunisation rates through the Health Protection Board, so that gives us an insight into what's happening.
Thank you, Robin. And it'll have to be the final question because we've got one item remaining on the agenda. So, Clive from Derbyshire Fire and Rescue.
Thank you, Chair. It's a very short one, I promise. It's not as impressive as some of the other speakers. Sorry about this. First of all, thank you for the report. It's fascinating. And it links in almost unerringly with some of the work that we do. So it's not so much a question, almost an awareness and offer, really. Our bariatric rescues have increased by about 500% in the last 2 years, which, again, links in, I'm going to say beautifully, but again, not particularly with the childhood obesity, which links into bariatric rescues, which we work closely with EMAS on. Again, over the last 2 years, we've had increasing suicides that we've had to go to, and again, increasing house fire deaths and so on. So the report that you've put together, it again matches, unfortunately, perfectly some of the things that we're seeing. So what the offers this year, we try and target about 14,500 of the most vulnerable at-risk households in Derbyshire every year. just increase it by this year. And again, we try to identify part of a risk stratification index. We get mosaic data and extra data from GPs and so on, just trying to identify the most at risk. The offer is, again, I fully appreciate we're an extremely small cog in the wheel. We really are. If we can be of any help at all, if we can get over the threshold of anyone that's struggling to reach, then again, our at-risk demographics are very similar to yours, I think. So you know where we are, and again, very small cog, but if there's any way we can possibly help, then please let me know.
Thank you. That's really helpful, and I think as part of obesity, we do often consider bariatric ambulance transfers and also bariatrics from a maternity perspective. All of those things we take into account, but I haven't ever thought of that bariatric rescues before. So thank you. That's really helpful.
Thank you, Clive, and thank you for the offer, because you're one of the services that it doesn't matter which ethnicity you are a favoured service. You have a service that can access properties, can get to people without any barriers in place, and so any offer of assistance is really appreciated.
Thank you. We make no apology. We do think we have got quite a good brand, and yeah, I think sometimes our colleagues in the police are sometimes a little bit jealous of us in a way. So, but yeah, like I say, and it goes to sort of, if any help we can possibly be at all. Again, we work very closely with Councillor Williams in a lot of the inclusion boards and a lot of the governance and performing working groups and that sort of thing. So, as the councillor knows, we do try and get involved as much as we possibly can. Again, appreciate we're a very small cog in the wheel, but if anything we can do to get anyone across the threshold, then we'll do what we can.
Okay, thank you, Clive. We've got 2 recommendations on this, and I've got to say that's the longest we've discussed a not quite finished report for a long time. So when it's fully available, it will be going out as widely as possible. So the 2 recommendations are 2.1, to note the content and issues raised in the Director of Public Health's Annual Report 2021, and to actively support the recommendations of the annual report set out in 4.7. Can I have a proposer for that? Councillor Williams, seconder. Seconder Steve Studham. You've been sat there quiet. Thank you, Steve. All those in favour? Thank you. Now it's over to you, Alison, and an update on the terms of reference for the Health and Wellbeing Board.
Thank you. And I will take you very briefly through this report. So I think it was our last Health and Wellbeing Board meeting. I think we agreed that we would make changes to our terms of reference to reflect the development work that we'd undertaken and to ensure that we're moving forward kind of within the way that we wanted to. So just under 4.5 of the cover report, the key changes in the terms of reference are highlighted there, but I'll just quickly take you through what those look like within the terms of reference themselves. So the first main addition is 2 under vision and objectives. So I've added those in to try and reflect the vision and objectives that we agreed as part of that development process. So then moving on to purpose and functions under E, this is kind of just a kind of minor change really in terms of amendment and links to kind of the ICS development work that was referenced by Dr. Clayton earlier. So it's really changing from a CCG to integrated care system. Very minor changes in F and G. I think we already had links or references to Joined Up Care and Derby Place partnership and linked the Derby Partnership Board, just kind of reflecting kind of more updated wording for those. In non-statutory membership, I think at the last meeting I kind of highlighted a number of changes to the membership, and we've got a couple of those additional members with us today. So they're all highlighted there. I think one thing I did want to pick up and perhaps just kind of get a view from the Health and Wellbeing Board, and I'll probably take it outside as well with our NHS colleagues. I think we're kind of not got any left in the room at the moment. But as it stands, so I'd left in that we had, so we currently have 4 representatives representing kind of our 4 provider organisations within the city, and we were wondering whether, rather than kind of individually kind of representing those provider organisations, whether we would request instead a further representative from the integrated care system being a provider representative potentially, rather than the kind of 4 organisations being individually represented. So that was, I guess, a question to the board, and also one I'll take out with our NHS representatives. So let's just take us through to the end, and then we'll perhaps come back to that, Chair. Yeah. So other change is in number 5, governance and reporting arrangements. So I've just updated the figure there to demonstrate the relationship with Derby Place Partnership and Integrated Care Partnership. On the bottom right of that figure, I've kind of referenced group supporting population health improvement, and there is kind of mapping work that I think I referenced at the last board. So mapping work currently underway to try and understand what groups and boards are already in existence that relate to kind of the outcomes and priorities that we've got. So I think there'll be a little bit more development in terms of kind of any formal subgroups to this board, but I'll bring that back to a future meeting. And then probably the main kind of other significant or kind of notable addition is in 6.6. So I've added a section on meeting principles and ways of working, which I think was really just to bring out some of the key themes in terms of ways of working that really came through as part of our development work. So I was proposing adding those into the terms of reference. And then I think finally, under 6.7 at the bottom of that page, just add an additional section just suggesting or proposing that the board holds regular development session, both either as an individual health and wellbeing board, but also joint sessions with the Derbyshire Health and Wellbeing Board that are kind of outside of the public domain for the development of the board. So in summary, that's a very quick run through of the main changes that are being proposed to the terms of reference, Chair.
Okay, thank you, Alison. So these are not for approval, are they?
No, they're for recommendation for ratification of the council.
So has to go to full council, and hopefully you'll have the conversation with our NHS colleagues about representation. I'm still concerned that EMAS is not represented, particularly with some of the health issues that we have around EMAS, but you know, we can look at that again before it's finalised with our health colleagues. Any other comments? In that case, shall we note it and wait for full council to approve our terms of reference as and if amended? Thank you very much, ladies and gentlemen, for your attendance. It's been a very wide-ranging and interesting meeting, and I hope to see you at our next meeting. And what's the date, Alison?
Not absolutely sure. I think we're just finalising those through. They'll be going through the AGM. Thank you. Thank you.
Okay,
but I think
so
it's the latter end of July is the proposed date.
Thank you very much indeed. You will be informed when the next meeting will take place. And again, I'm particularly pleased that we've had a meeting in person. So, thank you all. Bye.